discussing on the topic of heart failure recognition and management. So for my objectives at the end of this session, the students should be able to recognize the cardinal signs and symptoms of heart failure and identify physical examination findings that are consistent with heart failure, to be able to classify heart failure severity, to be able to understand the pathophysiologic mechanisms involved in heart failure and the clinical implications, and to know the evidence-based pharmacotherapy in the management of heart failure. Heart failure recognition. Heart failure. It is a clinical syndrome that results from structural or functional impairment of ventricular filling or the ejection of blood, which in turn leads to cardinal clinical symptoms of dyspnea, fatigue, and fluid retention. Heart failure is preferred over the older term, congestive heart failure, because many patients present without signs or symptoms of volume overload. Chronic heart failure means the patient has long-standing symptoms and/or signs of heart failure, whereas acute heart failure means there is rapid onset or worsening of symptoms of heart failure. Most episodes of acute heart failure is a result of worsening of the chronic heart failure condition, but 20% of acute heart failure is actually due to de novo or new onset heart failure that can occur in the setting of acute coronary syndrome, acute valvular dysfunction, or hypertensive urgency. Classifying patients in heart failure based on their left ventricular ejection fraction is important due to differences in the demographics, comorbidities, and response to therapy. Heart failure with reduced ejection fraction, HFrEF, means the ejection fraction is less than 40%. Heart failure with preserved ejection fraction, HFpEF, the ejection fraction is more than 50%. Heart failure with mid-range or mildly reduced EF have a EF between 40 and 50%. Heart failure with mildly reduced ejection fraction primarily have mild systolic dysfunction with features of diastolic dysfunction. They are treated with guideline-directed therapy that is similar to patients with HFrEF. Heart failure with recovered EF. It is a subgroup of patients diagnosed initially with HFrEF and treated with guideline-directed therapy will have a rapid and gradual improvement in their ejection fraction to the normal range. So what are the causes of heart failure? It can be due to a familial cause such as inherited cardiomyopathies. It can be acquired. It can be due to congenital disorder, and it can be due to other medical conditions, systemic diseases that have cardiac manifestation. So presented in Harrison's are some of the selected causes of heart failure that can lead to HFrEF, HFpEF, or high output heart failure states. So next we go on to evaluation of patients with heart failure. So getting a good history is important. The most common symptoms of heart failure are related to volume overload with elevations in the pulmonary and/or systemic venous pressure. So we look into the history for symptoms of congestion. The cardinal manifestation of left-sided heart failure is shortness of breath. Mechanisms of the dyspnea include pulmonary venous congestion and transudation of fluid into the interstitium or into the alveoli, leading to decreased lung compliance, increased airway resistance, hypoxemia, and ventilation perfusion mismatch. Stimulation of juxtacapillary J receptors lead to an increased ventilatory drive and reduced blood flow to the respiratory muscles, which can result in lactic acidosis and a sensation of dyspnea. The New York Heart Association functional class may be used to categorize patients based on the amount of effort required to provoke breathlessness. So as presented in Harrison's, this is the New York Heart Association functional class. With class 1 category, there is no limitation. Ordinary physical activity does not cause dyspnea. Class 2 patients have slight limitation. they are comfortable at rest, but ordinary physical activities such as carrying heavy packages or doing ordinary household chores may result in dyspnea. Class 3, there is marked limitation. They are still comfortable at rest, but less than ordinary physical activity, such as getting dressed, may lead to symptoms of dyspnea. Class 4, there is severe limitation. The symptoms of heart failure are present even at rest, and it is worsened when doing an activity. Shortness of breath may increase in severity as exertional dyspnea, orthopnea, PND, or dyspnea at rest. So what is orthopnea? This is dyspnea occurring in the recumbent position. It is due to redistribution of the fluid from the abdomen and lower body into the chest. The increased work of breathing is due to decreased lung compliance as well as due to elevations in the diaphragm, especially in patients with ascites or hepatomegaly. Orthopnea typically occurs in the awake patient within 1 to 2 minutes upon lying down, and it may be relieved by raising the head and chest with pillows. So in your history, you may get a history of 2 or 3 pillows required to find relief. So that is 2 or 3 pillow orthopnea. Orthopnea may be accompanied by nocturnal cough related to pulmonary congestion, and the symptom of orthopnea may diminish as the symptoms of right heart failure appear. Paroxysmal nocturnal dyspnea. This refers to episodes of shortness of breath that awaken the patient suddenly from sleep with feelings of anxiety and suffocation and require sitting upright for relief. This usually occurs after prolonged recumbency. PND is less predictable in occurrence, and it may require 30 minutes or longer in the upright position to give relief to the patient. The episodes of PND can be accompanied by coughing and wheezing, so-called cardiac asthma, which is due to increased bronchial arterial pressure that results in airway compression, and also as a result of interstitial pulmonary edema causing increased airway resistance. Some patients may present with acute pulmonary edema as a result of a marked elevation in the pulmonary capillary wedge pressure. This is manifested by severe shortness of breath, and they can present with pink, frothy sputum. Pulmonary capillary wedge pressure is an indirect measurement that estimates the left atrial and left ventricular pressures. It actually reflects how much fluid is in the left side of the heart. Cheyne-Stokes respiration and central sleep apnea. They can also be present in heart failure, and they precipitate episodes of PND in heart failure patients. It is related to the increased sensitivity of the respiratory center to arterial PCO2 and a prolonged circulatory time. Central apnea has no proven therapy beyond those given in the directed treatment of heart failure. Hence, symptoms of left heart failure is due to pulmonary venous congestion. What about symptoms of right-sided heart failure? This is related to systemic venous congestion. Usually in the history, patients may present with weight gain and lower extremity edema. This could be the initial manifestation followed by gastrointestinal symptoms, result from a edema of the bowel wall as well as presence of hepatic congestion. The patients can complain of abdominal bloatedness, anorexia, and early satiety, which is common. The presence of right upper quadrant pain may be related to stretching of the hepatic capsule, and they can have nausea and vomiting. Patients with refractory right-sided heart failure can develop massive edema that involves the entire body with recurrent pleural effusions and/or ascites, and this is termed anasarca. Also, in the history of patients with heart failure, you look for symptoms of reduced perfusion. Patients in advanced heart failure can present with symptoms related to decreased cardiac output, referred to as the low output syndrome. Low output syndrome, these patients can have fatigue and weakness of the lower extremities that can occur with exertion or at rest. It is due to reduced blood flow to the exercising muscle due to endothelial dysfunction and increased systemic vascular resistance from neurohormonal activation. Older patients with heart failure and a history of cerebrovascular disease, such as stroke, the reduced systemic perfusion may result in mental dullness, depressed affect, and confusion. Next in the history, we look for precipitating factors. Patients with heart failure may be asymptomatic or mildly symptomatic, either because the cardiac impairment is mild or because compensatory mechanisms help to balance or normalize the cardiac function. The symptoms of heart failure may develop when one or more precipitating factors increase cardiac workload and disrupt the balance, which favors decompensation. Specific factors may be identified and can be divided into patient-related factors, provider-related factors, or heart failure-related disease states, as well as other causes. So patients who are in heart failure but are not symptomatic can suddenly have a worsening of their heart failure because of increase in salt or water intake, non-adherence to medications for their heart failure, hence this is patient-related factors, or heart failure patients can be given medications which help retain salt and water, such as NSAIDs, or they've been prescribed the use of medications which have a negative inotropic property, so this is provider-related precipitating factors, or patients may have a sudden history of elevated BP, MI, arrhythmia, so this is heart failure-related precipitating factors, or other disease states such as getting a systemic infection can worsen their heart failure. So the table in Harrison just shows some of the precipitating factors for heart failure. Inability to recognize and correct these factors promptly lead to persistent heart failure state despite adequate treatment. So after the history, we go into physical examination of a heart failure patient, starting with general appearance. Patients with mild to moderate heart failure can appear well-nourished and comfortable at rest. Those in severe heart failure may present as anxious, diaphoretic, the need to sit upright. They can appear dyspneic at rest with pallor due to anemia or duskiness due to low cardiac output state. They can present with signs of cool extremities and peripheral cyanosis. Some patients can have cardiac cachexia, defined as unintentional edema-free weight loss of more than 5% over 12 months. This can occur in patients with long-standing severe heart failure, manifested as bitemporal or upper body muscle wasting. Cardiac cachexia is due to poor oral intake due to anorexia, due to decreased fat absorption as a result of bowel wall edema, and it can be due to catabolic-metabolic imbalance from activation of inflammatory cytokines present in heart failure. Next, we take by the vital signs of heart failure patients. For those who have new onset heart failure, their heart rate may be elevated and their BP may also be increased due to the sympathetic activation. Those with chronic heart failure and on guideline-directed medical therapy may have a resting heart rate that is ideally below 70 to 75 beats per minute and a blood pressure in the normal to low normal range. Those in severe heart failure may present with hypotension and a narrow pulse pressure, and they can also have a rapid threaded pulse. Pulsus alternans. It is an alternating strong and weak pulse. It is a result of reduced left ventricular contraction in every other cardiac cycle due to incomplete recovery, causing alternation in the left ventricular stroke volume. When you look at the respiratory rate of heart failure patients, it may be normal at rest, but may increase upon lying down or on minimal exertion. In the physical examination of a heart failure patient, it is important to look at the jugular venous pulse. Examination of the jugular veins provide an estimation of the right atrial pressure. We examine the patient in a 45-degree angle when they are supine. How do we get the JVP? We estimate the height of the venous column of blood above the sternal angle. When you add 5, the measurement of JVP is in centimeter water. In mild right-sided heart failure, the JVP may be normal at rest, which is less than 8 centimeter water, but it can increase when you apply continuous pressure over the liver for 15 to 30 seconds. This is the hepatojugular reflux test. If you do the abdominojugular test, this is an increase in the right atrial pressure during 10 seconds of firm mid-abdominal compression, followed by an abrupt drop in pressure upon release. If this occurs, it suggests there's the presence of elevated left-sided filling pressures. When looking at the JVP, if there's a prominent V wave and Y descent, this indicates the presence of significant tricuspid regurgitation. A rise in JVP with inspiration or your Kussmaul sign may also be due to the presence of severe biventricular heart failure. Lung examination. Pulmonary rales result from the transudation of fluid from the intravascular space into the alveoli and airways. In general, rales are heard at the lung bases. In severe heart failure or in acute pulmonary edema, the rales may be heard throughout the lung fields. Wheezing and rhonchi can occur with congestion of the bronchial mucosa. Rales are absent in patients with chronic heart failure because of increased lymphatic drainage, which prevents the spillage of fluid from interstitium into the alveoli. Patients with biventricular or predominant right-sided heart failure, they can present with bilateral pleural effusions, recognized as dullness to percussion and decreased breath sounds at the lung bases. If there is unilateral pleural effusion, usually it involves the right lung. So of course, in heart failure, it is important to do a cardiac examination. Chronic heart failure with ventricular remodeling is accompanied by cardiac enlargement. And on PE, this is presented as an apical pulse displaced downward and to the left, and it can be diffused in patients with dilated cardiomyopathy or sustained in patients with a pressure overload state such as aortic stenosis. In patients with biventricular or severe right-sided heart failure, they can present with a right ventricular heave or a parasternal lift that may be palpated along the left sternal border. On auscultation, it is important to listen for heart sounds, and if there's the presence of a S3 gallop, this is usually commonly seen in patients with volume overload, and this suggests the presence of severe hemodynamic compromise. The presence of an S4 gallop is not specific to heart failure, but it may be present in patients with HFpEF due to hypertension. If there is holosystolic murmur, this can be due to the presence of mitral and tricuspid regurgitation. And patients who have secondary pulmonary hypertension will have a loud pulmonary component of the second heart sound, what we call a loud P2. Next is abdominal examination and examination of the extremities. Hepatomegaly is an early sign of systemic venous congestion, and you may be able to elicit the liver edge as tender as a result of a stretching of the capsule and may be pulsatile if tricuspid regurgitation is present. Long-standing hepatic congestion results in cardiac cirrhosis with congestive splenomegaly and ascites. If a patient with heart failure presents with massive ascites, you should still investigate for other causes such as the presence of constrictive pericarditis or a primary liver failure. For the extremities, dependent lower extremity edema is common in chronic heart failure. Typically, the edema of the lower extremities are symmetric and they present with pitting edema. Chronic edema may cause reddening and induration of the skin. It may become weeping or lead to cellulitis. Anosarca describes massive generalized edema that involves the legs, the sacrum, and abdominal wall. So what are the tests involved in the diagnosis of heart failure? The diagnosis of heart failure is actually relatively straightforward when the patient presents with typical signs and symptoms. It is important to have a high index of suspicion for heart failure, especially in populations that are at increased risk, such as older patients, those with underlying cardiovascular disease, and with known comorbidities such as hypertension, chronic kidney disease, and diabetes. So, in patients presenting heart failure, the routine laboratories can be done. Standard lab testing includes a comprehensive metabolic panel, complete blood count, coagulation studies, and urinalysis. Selected patients should have assessment for diabetes, dyslipidemia, and thyroid abnormalities. So some of the routine labs that can be taken include your electrolytes. You may see hyponatremia due to sodium restriction, because of the use of diuretic therapy and vasopressin-mediated free water retention. They can also present with hypokalemia due to the use of thiazide or loop diuretics as their medications. The presence of hyperkalemia may be the result of marked reductions in glomerular filtration rate and exacerbated with use of RAS inhibitors and potassium-sparing diuretics. For the CBC, some heart failure patients may present with anemia. Anemia is not diagnostic of heart failure, but if present, it may exacerbate the underlying cardiac conditions such as ischemic heart disease. Iron deficiency with or without anemia. If present in the labs, it can be attributed to the decreased gut reabsorption, impaired hepatic storage, and chronic blood loss. Electrocardiogram, ECG. A routine 12-lead ECG is recommended in heart failure patients. There are no specific ECG pattern that is actually diagnostic of heart failure. By taking the ECG, it provides important information regarding the presence of an underlying cardiac disease. So we may see left ventricular hypertrophy or left atrial enlargement, and that can be due to certain conditions such as hypertension, aortic stenosis, or hypertrophic cardiomyopathy. If there is a presence of Q waves or infarction, it suggests there is an underlying ischemic heart disease. Q waves with reduced QRS voltage or the pseudo-infarct pattern can be seen in restrictive or infiltrative cardiomyopathies. ECGs may also show certain arrhythmias such as atrial fibrillation, and if it's present in heart failure patient, it is an indication that they should be anticoagulated. Also in the ECG, we look at the QRS width, and if there is the presence of a left bundle branch block pattern, as it will help us to ascertain the benefit of doing a cardiac resynchronization therapy or CRT in the heart failure patient. Chest X-ray. The chest X-ray provides useful information about the cardiac size and shape, as well as the state of the pulmonary vasculature. On chest X-ray, imaging associated with left heart failure include an enlarged cardiac silhouette, meaning the cardiothoracic ratio is more than 0.5, and the presence of pulmonary venous congestion. In acute heart failure, early radiologic signs include upper zone venous distribution and thickening of the interlobular septa. If the pulmonary capillary wedge pressure is moderate to severe, alveolar edema is present as diffuse haziness that extends downwards towards the lower lung fields. Absence of these findings of venous congestion, pulmonary venous congestion in patients with chronic heart failure reflects that there's an increased capacity of the lymphatics to remove interstitial or pulmonary fluid. Pleural effusion on chest X-ray is common in biventricular heart failure, and we also do your chest X-ray because it helps to identify non-cardiac causes of dyspnea in the patient. Other diagnostics are non-invasive imaging studies. Non-invasive cardiac imaging is essential for the diagnosis, evaluation, and management of heart failure. 2D echo. It is the single most useful test in evaluating the cause of patients with acute heart failure. It helps to assess the left ventricular size and function, the valvular morphology and function, and it helps to detect intracavitary thrombi and the presence of pericardial effusion. In 2D echo, we have Doppler studies or Doppler techniques which help to estimate, compute the cardiac output, helps to let us know what is the pulmonary artery pressures, calculate valve areas, and helps to detect abnormalities in the left ventricular diastolic filling pressures, especially in patients with HFpEF. For patients with end-stage heart failure, the echo is critical for the assessment of the right ventricular function before and after circulatory support and heart transplant. Cardiac magnetic resonance imaging, CMR, it is actually highly accurate and quantitative tool for the evaluation of LV mass, volumes, and function, as well as for determining actual specific causes of heart failure. We can determine if the heart failure is due to ischemic, inflammatory conditions such as myocarditis, due to amyloidosis or hemochromatosis. CMR is helpful in defining multiple anatomic and functional abnormalities in adults presenting with congenital heart disease, and doing a serial CMR study can assess ventricular remodeling in response to therapy, which is useful in clinical research. To help diagnose heart failure, we also check for certain biomarkers. These are your natriuretic peptides. Circulating levels of natriuretic peptides are useful and important adjunctive tool in the diagnosis of patients with heart failure. Both the B-type natriuretic peptide and N-terminal proBNP are released from the atria and ventricles in response to increased wall stress. HFrEF have higher levels of the natriuretic peptides than patients with HFpEF. And the levels of natriuretic peptides can actually be falsely low in patients who are obese. In ambulatory patients complaining of dyspnea, doing the natriuretic peptides is useful to support clinical decision-making regarding the diagnosis of heart failure in the setting of clinical uncertainty, or if the patient also has concomitant lung disease and you do not know if the dyspnea is due to the lung disease or there's actually a cardiac problem. The levels of natriuretic peptides may be also useful to establish disease severity and prognosis in patients in chronic heart failure. You just have to also know that natriuretic peptides can also be elevated in increased age, in the female sex, and in chronic kidney disease, so not necessarily elevated because of heart failure. Other cardiovascular diseases, such as the presence of atrial fibrillation, pulmonary embolism, and pulmonary arterial hypertension, can also increase the BNPs. Do we do invasive studies for patients with heart failure? Invasive studies such as the pulmonary artery catheter, it assesses the cardiac filling pressures and cardiac output to differentiate cardiogenic from non-cardiogenic pulmonary edema and to manage hemodynamic instability in the ICU setting. Putting in a pulmonary artery catheter can be performed safely at bedside, and it is used to determine the response to intravenous vasoactive and diuretic therapy in severe heart failure patients. But we don't always put in a pulmonary artery catheter. Other invasive studies can include coronary angiography. This is to exclude ischemic heart disease as an underlying, potentially reversible cause of left ventricular dysfunction. We do the coronary angiogram if we think that the patient's cause of the heart failure is due to a ischemic condition and we would like to know if they have an underlying coronary artery disease. Many signs and symptoms suggesting heart failure may be caused by other condition. Hence, we must have differential diagnosis of patients who actually present with dyspnea or swelling of the lower extremities. Patients with dyspnea, we must be able to distinguish cardiac from pulmonary causes. Differentiating dyspnea related to heart failure versus pulmonary disease may be impossible when the diseases coexist, and this is common in patients who are older with an active or prior smoking history. So, following diuresis, you can do a pulmonary function test to also help determine if the predominant cause of dyspnea is due to a lung problem. Heart failure needs to be distinguished from conditions, one in which there is congestion secondary to abnormal salt and water retention, but there is no disturbance in the cardiac structure or function. So, example would be renal failure. And another condition heart failure must be distinguished from are non-cardiac causes of pulmonary edema, such as acute respiratory distress syndrome. A very low BNP or NT-proBNP may be helpful in excluding heart failure as a cause of dyspnea in non-obese patients. And then you have the non-heart failure causes of lower extremity edema, such as venous insufficiency, lymphedema, and obesity as a differential diagnosis. So again, Harrison's has put in certain differential diagnoses for patients who present with dyspnea, edema, ascites, pleural effusion, and jugular venous distension, not necessarily because of heart failure. So I will just impasse the pathophysiology of heart failure, the mechanisms that make it a progressive disease. By knowing these mechanisms, you will understand the management because it targets these mechanisms that are activated in heart failure. HFrEF typically involves an index event followed by months to years of structural and functional cardiovascular remodeling. The primary event may be sudden in onset, such as acute MI. The index event may be gradual in the setting of a chronic pressure or volume overload. The index event can be inherited, such as in genetic cardiomyopathies or congenital. Despite initial reduction in the cardiac performance, patients may actually be asymptomatic or mildly symptomatic for prolonged periods due to activation of compensatory mechanisms that ultimately lead to disease progression. So from the index event, the heart will start to remodel. So ventricular remodeling is in response to excess cardiac workload. The type of remodeling is as follows: concentric hypertrophy, which means there's an increased mass that is out of proportion to chamber volume to effectively reduce wall stress under conditions of pressure overload. Eccentric hypertrophy means that there is an increase in the cavity size or volume in volume overload conditions. So with ventricular remodeling, at the cellular level, there is myocyte hypertrophy and interstitial fibrosis. At the protein level, there is alteration in the calcium handling and cytoskeletal function. At the molecular level, there is re-expression of fetal genes. Cell loss from necrosis and myocytes that are unable to adapt to remodeling stimuli may undergo apoptosis or programmed cell death. These events feed back on the remodeling stimuli and set up a cycle that is deleterious process that results in clinical heart failure. Ventricular remodeling in HFrEF is actually well understood, but the mechanisms that underlie HFpEF is actually less clear. So what are the mechanisms that result in a heart failure to progress? So in heart failure, there are certain compensatory mechanisms which become activated during the development of heart failure and actually contribute to the disease progression. That is the neurohormonal activation. When we say neurohormonal activation, this is the sympathetic nervous system and the renin-angiotensin-aldosterone system. These two actually have a critical role in the development and progression of heart failure. When the neurohormonal activation systems are set into play, they initially lead to increase in heart rate, an increase in blood pressure, increase in cardiac contractility, and retention of sodium and water to augment preload to maintain the cardiac output at rest and during exercise. Over time, these compensatory response become unchecked, which can lead to excessive vasoconstriction and excessive volume retention, leading to electrolyte and renal abnormalities. It can also result in direct myocardial toxicity as well as cardiac arrhythmias. At the tissue level, there is already remodeling of the heart, the blood vessels, the kidneys, and other organs, which result in the development of symptomatic heart failure. Hence, the landmark clinical trials in which there is antagonism of the RAS and SNS with renin-angiotensin system inhibitors, mineralocorticoid receptor antagonists, and beta blockers reverse this ventricular and vascular remodeling and help to reduce morbidity and mortality in heart failure. Another mechanisms that help to progress the disease within heart failure is the presence of vasodilatory hormones. Counter-regulatory hormones are upregulated and exert beneficial effects on the heart, kidney, and vasculature. These are your natriuretic peptides, your ANP and BNP, prostaglandin, prostacyclin, bradykinin, and nitric oxide. ANP and BNP are stored and released by the atria and ventricles respectively, and they are released in response to the stretch or pressure of the atria and ventricles. The beneficial actions are actually mediated through the stimulation of guanylate cyclase, and the effects is to include vasodilation, increased sodium and water excretion, and inhibits the renin and aldosterone. The vasodilatory hormone bradykinin and the natriuretic peptides are actually inactivated by neprilysin. Hence, The drug which inhibits neprilysin has beneficial and clinical impact in the treatment of heart failure. So what are the other mechanisms that actually help disease progression in heart failure? A novel biologic target is the sodium glucose cotransporter 2, or your SGL2. This is a protein located on the proximal tubule of the kidney and is responsible for reabsorption of up to 90% of filtered glucose. In heart failure, the activity of your SGL2 results in sodium and water retention. It can lead to endothelial dysfunction, abnormal myocardial metabolism, and impaired calcium handling. Hence, the inhibitors of the SGL2 for the treatment of type 2 diabetes takes advantage of the glycosuric and metabolic effects. Large trials of SGLT2 inhibitors in patients with heart failure have demonstrated its beneficial effects on the morbidity and mortality in heart failure. Another mechanism that results in disease progression in heart failure is desynchrony and electrical instability. In heart failure, disease progression is associated with prolongation of the QRS interval. Electrical desynchrony in the form of the left bundle branch block or intraventricular delay results in abnormal ventricular contraction. Patients with symptomatic HFrEF and a left bundle branch block pattern who are on guideline-directed medical therapy, it is indicated to do CRT in order to reduce morbidity and mortality. Other mechanisms of disease progression in heart failure is cardiorenal and abdominal interactions. In heart failure, presenting signs and symptoms are actually related to end organ failure, including dysfunction of the kidney, liver, and lungs. The heart and kidney interaction increases volume, which worsens the symptoms of heart failure and results in progression of heart failure, and this is referred to as the cardiorenal syndrome. For the cardiorenal syndrome, traditionally the relationship was deemed to be due to impaired forward flow due to low cardiac output, leading to decrease in renal arterial perfusion. Systemic venous congestion with increased backward pressure may be actually the operative in determining the development of the cardiorenal syndrome, because relief of venous congestion is associated with significant improvement in the renal function in patients in heart failure. An increase in intra-abdominal pressure, which is noted in patients with right-sided heart failure, and a rise in abdominal congestion are correlated with renal dysfunction in patients who are actually having a worsened heart failure symptom or state. There is also another mechanism for disease progression, such as gut congestion, the microbiome, and inflammation. Levels of pro-inflammatory cytokines are elevated in heart failure. The primary source of inflammation is actually unknown. Emerging evidence suggests that an alteration in gut microbial composition and loss of microbial diversity play an important role. The potential role of gut congestion and altered gut microbial composition may propagate this chronic state of inflammation and immune system dysregulation that actually leads to the progression of HFrEF. Now we go on to heart failure management. So the stages of heart failure. This is not actually in Harrison's, but I want to show you that we also classify heart failure patients into different stages. This is the American College of Cardiology, American Heart Association Heart Failure Staging System, which classifies heart failure progression into 4 stages. Stage A is at risk for heart failure. in which the patients have risk factors to have heart failure. They have hypertension, diabetes, obesities, but the heart function is still normal. Stage B or pre-heart failure. These are patients without symptoms or signs of heart failure, but they already have evidence of a structural heart disease and evidence of increased filling pressures. Stage C, this is already symptomatic heart failure, meaning patients with current or have previous symptoms of and signs of heart failure. Stage D is actually advanced heart failure. These patients have marked heart failure symptoms, required hospitalization despite attempts to optimize guideline-directed medical therapy. Basically, stage D is end stage. By putting this different staging system of heart failure, this framework helps to guide intervention, aims to prevent heart failure in the early stages, and the management of symptoms and progression of heart failure in the later stages. So clinical management of patients with heart failure will be based on their clinical phenotype at presentation. So those in stage A, basically it is to manage the risk factors to prevent heart failure. So that is BP control, advise healthy lifestyle, control sugars. Once they go into stage B, in which there is the presence of structural heart disease, they may be amenable to treatment with neurohormonal antagonists. These are your ACE inhibitors, ARBs, beta blockers. For patients who progress to stage C, meaning they are already symptomatic and in heart failure, they require interventions aimed to alleviate these symptoms. Those in stage C, the approach to therapy will also be based on their left ventricular ejection fraction. While stage D, in those with advanced heart failure, basically they will have to undergo or require salvage therapy, which include heart transplant, mechanical circulatory support such as the LV assisted device, or these patients are now for palliative care. So what is the management of heart failure with preserved ejection fraction, HFpEF? The general principles. In HFpEF, there is lack of evidence to support any specific pharmacologic therapy to modify disease progression. Basically, the goal of therapy is symptom focused, meaning if congestion is present, control the congestion. If the patient has high blood pressure, control BP to guideline recommended targets. Stabilize heart rhythm. If the patient is known to have atrial fibrillation, then you control the heart rate or consider converting them to sinus rhythm with other medications. If they have myocardial ischemia, treat and prevent MI. If there is sleep apnea, detect and treat the sleep apnea. Basically, manage comorbidities that may contribute to disease progression and encourage healthy lifestyle. Basically, for clinical trials in HFpEF, the attempts to exploit the benefit of drugs that improved clinical outcomes in HFrEF patients, they have been unsuccessful when done on HFpEF patients. Hence, it is actually hard to treat HFpEF patient in terms of what actual drugs to give them. In contrast to the disappointing results of targeted drug therapy in HFpEF, small studies of exercise training in patients with HFpEF have shown that there is benefit on functional capacity and quality of life. Hence, there's a possible role of lifestyle intervention to improve cardiorespiratory fitness in patients with HFpEF. Other targets or treatment therapy for patients with HFpEF include enhancing nitric oxide bioavailability. So there are trials which use phosphodiesterase 5 inhibitors such as sildenafil or nitrates using isosorbide mononitrate. But there are actually no guidelines yet for the use of sildenafil or nitrates in the treatment of HFpEF itself. There is also the angiotensin receptor neprilysin inhibition, the ARNIs, in which the drug is a combination of sacubitril and valsartan. So the Paragon heart failure trial has showed that there is a 13% reduction in the endpoint of cardiovascular death and hospitalization for heart failure. Using ARNI has also showed benefits in the secondary endpoints such as improved quality of life, improvement in the New York Heart Association class, as well as renal function. Hence, these studies favor sacubitril valsartan with modest benefits in patients with HFpEF. Hence, because of this Paragon heart failure trial, sacubitril valsartan has been approved for treatment of symptomatic heart failure across the full spectrum of EF. So, the ARNI is not only limited to HFrEF and HF mid-range EF patients, but you can also give ARNIs in patients with HFpEF. Basically, the clinical guiding principle in management of HFpEF is that in the absence of evidence-based targeted medical therapy, treatment of patients with HFpEF should just focus on decongestion by relieving the volume overload with diuretics, aggressive management of medical comorbidities such as aggressive control of BP to guideline recommended targets, aggressive management for at-risk coronary artery disease, such as you must evaluate if ischemia is present and reconsider revascularization. Focus on relieving the exacerbating factors. If the patient presents with atrial fibrillation, then there should be aggressive rate control and the use of anticoagulation. Exercise intolerance in HFpEF is a manifestation of chronotropic insufficiency. Should it be corrected with the use of rate-responsive pacemakers, this remains inadequately investigated. Hence, we do not actually do this for HFpEF patients, putting in a pacemaker. So, how do we manage patients who come in with acute decompensated heart failure? When we say acute decompensated heart failure, it is a clinical syndrome most often resulting in need for hospitalization due to interrelated abnormalities of decreased cardiac performance, the presence of renal dysfunction, and alterations in vascular compliance. Acute decompensated heart failure is associated with excessive morbidity and mortality, with nearly half of these patients readmitted for management within 6 months and have a high short-term and long-term cardiovascular mortality. The long-term outcomes remain poor for acute decompensated heart failure, with a combined incidence of cardiovascular death, heart failure hospitalization, MI, stroke, or sudden cardiac death reaching 50% at 12 months after hospitalization. Management has remained difficult and it revolves around volume control and hemodynamic optimization to maximize end organ perfusion. So for the management of acute decompensated heart failure, the general principle is to identify and address the factors that precipitated the decompensation. So you look into the history of non-adherence to the medications prescribed, look at their dietary salt intake, look at the medications that they have been taken or have been prescribed that may exacerbate the heart failure condition, such as NSAIDs, herbal preparations. Look into history if they've had any atrial or ventricular arrhythmias. Look into if the patient has a systemic infection or the presence of a pulmonary thromboembolism that can cause the acute decompensation. Pharmacologic therapy in acute decompensated heart failure is directed at hemodynamic optimization, including the relief of the congestion, reduce the afterload, and maximize perfusion of vital organs. Basically, the routine use of a pulmonary artery catheter is not recommended. Putting in a PA catheter is restricted to patients with features of low output failure or in cardiogenic shock who require vasopressor or mechanical circulatory support, or if they are resistant to diuretic therapy and with cardiorenal dysfunction. The parameters that are associated with worse outcomes in ADHF is elevated BUN, elevated creatinine, a systolic blood pressure that is less than 115 millimeter mercury, and if they have elevated cardiac troponins and natriuretic peptides upon evaluation. So in ADHF, treatment for volume management includes the use of intravenous diuretic agent. IV diuretic agent provides rapid and effective relief of symptoms of congestion and are essential when the oral drug absorption is impaired. When high doses of diuretic agents are required or when the effect is suboptimal, a continuous infusion may be needed of IV diuretic agents to reduce toxicity and maintain stable serum drug levels. Effective decongestion is confirmed if there is improvement in the clinical symptoms, if the JVP is normalized, if there is clearance of RALs upon auscultation, suppression of cardiac gallops, and if there's resolution of your peripheral edema. Continuous diuresis is done until euvolemia has been achieved in the patient. Another way to manage volume is ultrafiltration. This is invasive fluid removal technique that may be supplement or can supplement the need for diuretic therapy. The benefits of ultrafiltration include controlled rates of fluid removal. It has neutral effects on serum electrolytes, and it decreases neurohormonal activity. Thus, ultrafiltration is also referred to as aquapheresis due to its electrolyte depletion sparing effect. Another management in ADHF is vasoactive therapy, meaning the use of vasodilators such as intravenous nitroglycerin, sodium nitroprusside, and nesiritide. They are used to lower intracardiac filling pressures and to reduce systemic vascular tone. The rapid reduction in ventricular preload and afterload with these therapies may be effective in providing symptom relief in patients with pulmonary edema and in restoring end organ perfusion for those with a low cardiac output and high systemic vascular resistance state. Nitroglycerin affects the venous tone and the ventricular preload, while sodium nitroprusside has a potent arterial and venous dilatory effect with comprehensive effects on both the preload and afterload. In ADHF, patients may also require inotropic therapy. Positive inotropic agents, or what you call your inotropes. They increase intracellular concentration of the cyclic adenosine monophosphate, which results to an increase in cytoplasmic calcium, which will increase cardiac contractility. Hence, your inotropes, in essence, try to improve the cardiac contraction. Your inotropes are your dopamine and dobutamine, which act by a direct pathway, and the phosphodiesterase 3 inhibitor milrinone, which acts via indirect pathways. So in patients with a low output state, inotropes will augment cardiac output. It helps to reduce systemic vascular resistance, which in turns will improve perfusion and help relieve congestion acutely. For dopamine, this has a dose-dependent effect on the dopaminergic, alpha-adrenergic, and beta-adrenergic receptors. So if you give dopamine at low doses, it will have a predominantly vasodilatory effect. If you give it in moderate doses, it will have effects on the beta-adrenergic receptor, hence it increases contractility. But if you give dopamine in higher doses, meaning more than 10 micrograms per kilogram per minute, it will act on the alpha-adrenergic receptors, resulting in vasoconstriction. For milrinone, there is greater reduction in systemic and pulmonary vascular resistance, hence it carries a higher risk of systemic hypotension. Milrinone has a longer half-life and is renally excreted, hence it requires dose adjustment in the setting of kidney dysfunction. Milrinone acts downstream from the beta-1 adrenergic receptor, which is an advantage in patients who actually receive beta blockers. Long-term inotropic therapy is associated with a heightened risk of mortality in heart failure patients due to an increased risk in arrhythmia and sudden death. Inotropic agents are currently indicated principally for short-term use as a bridge therapy or can be used in cardiogenic shock or used as palliation in patients who are already at the end stage of their heart failure. Of course, in acute decompensated heart failure, patients may have a cardiorenal syndrome. Again, as stated, it is an interplay between the abnormalities of the heart and kidney function, with deteriorating function of one organ while giving therapy to preserve the other. Approximately 30% of patients who are hospitalized for ADHF exhibit abnormal renal function already at baseline, and this is associated with longer hospitalization and an increased mortality. In patients with established heart failure, cardiorenal syndrome represents a complex interplay of neurohormonal factors, potentially exacerbated by a backward failure, resulting from increased intra-abdominal pressure and impairment in return of renal venous blood flow. Continued use of diuretic therapy may be associated with a reduction in glomerular filtration rate and a worsening of the cardiorenal syndrome when right-sided heart filling pressures remain elevated. In patients in the late stages of disease, which is characterized by profound low cardiac output state, the use of inotropic therapy or mechanical circulatory support has shown to preserve or improve renal function in selected individuals. This can be given in short term until more definitive therapy such as assistive circulatory device or cardiac transplantation is implemented. Now we go to the management of patients with reduced ejection fraction, HFrEF patient. The treatment of symptomatic heart failure has evolved from the renocentric model, the use of diuretics, evolved from the hemodynamic model using digoxin inotropic therapy, to an era of disease-modifying therapy which are neurohormonal antagonists. These are your RAS blockers, the ACE and ARBs, the beta blockers, the mineralocorticoid receptor antagonists, and the newer targets or newer drugs are your neprilysin inhibitors, the ARNIs, and the sodium glucose cotransporter 2 inhibitors. These form the pillars of pharmacotherapy in HFrEF because they facilitate stabilization, the improvement in cardiac structure and function with consequent reduction in symptoms for patients in heart failure. Starting with the neurohormonal antagonists. Renin-angiotensin-aldosterone blockers, which are your ACE inhibitors and ARBs, and the beta blockers form the cornerstone of pharmacotherapy. There is a 23% reduction in mortality and a 35% reduction in the mortality and hospitalization of heart failure patients who are treated with ACE inhibitors. When you also add beta blockers, it provides a further 35% reduction in mortality on top of that benefit provided by ACE inhibitor alone. There is comparable efficacy of your ARBs and ACE inhibitors in HFrEF. Hence, ARBs are suitable alternative for patients who cannot tolerate your ACE inhibitors due to cough or the presence of angioedema. The efficacy of your neurohormonal antagonists are seen across the full spectrum of heart failure severity. ACE inhibitors and ARBs exert their beneficial effects in HFrEF as a class, whereas the beneficial effect of beta blockers are actually limited to specific drugs such as your carvedilol, bisoprolol, and metoprolol succinate because they have been tested and proven to improve survival in HFrEF patients in clinical trials. When you do trials on the doses of ACE inhibitors and beta blockers to be given, these studies favor higher doses with a reduction in the rates of death and hospitalization. Hence, for heart failure management, we titrate the medications to the maximum, which was stated in trials, to have that benefit in the reduction of death and hospitalization. In the management of HFrEF, there are novel neurohormonal antagonists. It has shown that there are activated neurohormonal pathways beyond the RAS and sympathetic nervous system. And it has been demonstrated that these are deleterious, and by targeting such pathway with incremental blockade has actually been unsuccessful. So we have such combinations of drugs, ACE inhibitor and neprilysin inhibition. The risk of angioedema was related to excessive blockade of the bradykinin breakdown with this combination. But with the blockade of the angiotensin at the receptor level using your ARB, leaves an intact ACE pathway for the bradykinin breakdown. This results in an actually lower angioedema risk. So instead of using ACE inhibitors combined with neprilysin inhibitor, it is better, or it has shown that the combination of ARB and neprilysin inhibitor has a lower angioedema risk. So what is this angiotensin receptor neprilysin inhibitor, or what we call the ARNI? It is again the combination of the ARB valsartan with an endopeptidase inhibitor called sacubitril. It is marketed as Entresto or Vimada here in the Philippines. This drug was tested in the Paradigm heart failure trial in which they used valsartan alternatively instead of the ACE inhibitor. From the Paradigm heart failure trial, it showed an incremental improvement in survival when compared to ACE inhibitors alone or ARB alone. There was a 20% reduction in cardiovascular death or heart failure hospitalization. Hence, guidelines advocate a switch to ARNI for symptomatic HFrEF treatment, especially in those who tolerate ACE inhibitors and ARBs. You do not use ARNI or it is contraindicated in patients with a history of angioedema, and if you are transitioning a patient from initial ACE inhibitor drug, if they will be treated with ARNI, there should be a 36-hour gap from the last intake of the ACE inhibitor to limit the risk of an overlap of the ACE and ARBs. Another neurohormonal antagonist in the treatment of HFrEF is the mineral corticoid antagonist, your MRAs. Elevated aldosterone levels in HFrEF promote sodium retention, electrolyte imbalance, and endothelial dysfunction, which can directly contribute to myocardial fibrosis. Aldosterone antagonists added to the treatment with ACE or ARBs and beta blockers in symptomatic HFrEF is associated with a reduction in morbidity and mortality as well as hospitalization for heart failure. So what are the MRAs? These are your spironolactone, which is most commonly used. Its efficacy in heart failure was demonstrated in the RALS studies in patients who actually have HFrEF with a New York Heart Association class 3 to 4 symptoms. Another type of MRA is your eplerenone, which can be given with patients with milder New York Heart Association class 2 symptoms or who have post-myocardial infarction heart failure. Eplerenone actually lacks the anti-androgen effects that is seen with spironolactone. So, there is no gynecomastia, no erectile dysfunction, or diminished libido in patients who take eplerenone. HFrEF treated with alternative vasodilators. The combination of hydralazine and nitrate has been demonstrated to improve survival in HFrEF, but to a lesser extent than that of ACE inhibitors. Using hydralazine reduces systemic vascular resistance and induces arterial vasodilation by affecting intracellular calcium kinetics. Nitrates are transformed in the smooth muscle cell into nitric oxide. This in turn stimulates your cyclic guanosine monophosphate production and a consequent in arterial venous vasodilation. In HFrEF, we also use heart rate modifiers. Such drug is ivabradine. It is an inhibitor of the IF current, or what we call the funny channel in the sinoatrial node. It selectively reduces heart rate without affecting cardiac contractility or the vascular tone. The SHIFT trial using ivabradine in patients with New York Heart Association Class 2 or 3 HFrEF, ivabradine reduces cardiovascular-related death and heart failure hospitalization in proportion to the degree of heart rate reduction. Hence, because of the SHIFT trial, it supports the notion that the heart rate may be a therapeutic target in patients with HFrEF who are in sinus rhythm. We do not give ivabradine in patients who are in atrial fibrillation. Ivabradine may be considered in patients with HFrEF who remain symptomatic even if they are already on guideline-based therapy with ACE, ARBs, ARNI, beta blockers, MRAs, who are in sinus rhythm and still have a residual heart rate of more than 70 beats per minute. We also give SGLT2 inhibitors in HFrEF. SGLT2 inhibitors reduce cardiovascular events and mortality among patients with type 2 diabetes with a high CV risk. Benefits have been seen with a reduction in the incidence of heart failure hospitalization in patients who are taking empagliflozin. This is the EMPA-REG outcomes. There is also a significant 26% reduction in worsening heart failure or death from cardiovascular causes in patients with or without diabetes who are symptomatic with HFrEF and they are treated with dapagliflozin. This is the DAPA heart failure study. Because of these trials, the consensus guidelines approve the use of SGLT2 inhibitors as part of the foundation therapy for heart failure patients, along with your ACE inhibitors, ARBs, and/or ARNIs, beta blockers, and MRAs. Other drugs that may be used in HFrEF management are your soluble guanylyl cyclase stimulation. Soluble guanylyl cyclase, or your SGC, is a key enzyme for the nitric oxide signaling pathway, which results in the synthesis of your cyclic guanosine monophosphate that will produce vasodilation. The drug is vericiguat. It is a novel oral SGC stimulator. In the Victoria study using vericiguat, results have showed a modest 10% relative risk reduction in the primary outcome of cardiovascular death or heart failure hospitalization. This drug is tolerated well with low rate of serious adverse events. Hence, a potential role of SGC stimulation as an adjunct to guideline-directed medical therapy can be given in high-risk group of HFrEF patients. What other drugs can be used in the management of HFrEF? We have digoxin. This is a digitalis glycoside which exerts mild inotropic effect and are sympatho-inhibitory. These effects decrease serum norepinephrine levels, they decrease plasma renin levels, as well as a decrease in possible aldosterone levels. The DIG study using digoxin showed a reduction in heart failure hospitalization, but there was no reduction in mortality or there was no improvement in quality of life for these heart failure patients. Low doses of digoxin can be used to achieve potentially beneficial outcomes, but if you give higher doses, patients are at risk for digital toxicity. Digoxin is actually a late-line therapy. It is for patients who remain profoundly symptomatic despite optimal neurohormonal blockade and adequate volume control. So in heart failure or HFrEF patients, we can also give oral diuretic drugs. Basically, neurohormonal activation in heart failure results in salt and water retention. Diuretic therapy is typically required in patients with symptomatic heart failure, and to treat congestive symptoms is a must prior to the initiation and titration of neurohormonal therapy. So we can give them loop diuretics, which has a potent effect on renal sodium excretion. Loop diuretics are actually the preferred diuretic agent, but we can also give thiazide diuretics, which is reserved for use in combination with loop diuretics if patients have refractory volume overload. Other medications in HFrEF, calcium channel blockers. Second-generation agents such as amlodipine and felodipine safely and effectively reduce blood pressure in HFrEF but do not affect morbidity and mortality or quality of life. First-generation agents such as verapamil and diltiazem, they exert negative inotropic effects and destabilize previously asymptomatic patients. Thus, they are contraindicated in patients with HFrEF. Fish oil. Treatment with long-chain omega-3 polyunsaturated fatty acids has only shown modest improvement in clinical outcomes in patients with HFrEF. Another drug for HFrEF management is your HMG-CoA reductase inhibitors or your statins. Potent lipid-altering and pleiotropic effects of statins reduce major cardiovascular events and improve survival in non-heart failure populations such as diabetics, post-stroke patients, ischemic, and patients with coronary artery disease. Once heart failure is well established in the patient, the therapy with statins may not be as beneficial. Thus, statins are not routinely indicated for non-ischemic heart failure. There is evidence that suggests an association between heart failure and the micronutrient status of the patient. Reversible heart failure as a consequence of severe thiamine and selenium deficiency. Thiamine deficiency has received attention in heart failure due to the fact that malnutrition and diuretics are prime risk factors for thiamine loss. But currently, there are no recommendations for the routine supplementation with thiamine or for the testing of HFrEF or heart failure patients for thiamine deficiency. HFrEF is accompanied by a hypercoagulable state, and therefore these patients are at high risk of having a thromboembolic event such as stroke, pulmonary embolism, and peripheral artery embolism. Hence, in HFrEF management, some patients may require anticoagulation, such as the use of a vitamin K antagonist such as warfarin, or your non-vitamin K antagonist oral anticoagulants, or what we call your direct oral anticoagulants. We only use anticoagulate if the patient has atrial fibrillation in the presence of HFrEF, or there is a history of thromboembolic events, or there is an echo evidence of the presence of a left ventricular thrombus formation. Antiplatelets such as aspirin or clopidogrel are usually used in HFrEF patients due to ischemic cardiomyopathy who do not have a contraindication for antiplatelet use. In HFrEF, we may also consider cardiac resynchronization therapy. Basically, in some heart failure patients, there is non-synchronous contraction between the walls of the left ventricle or non-synchronous contraction between ventricular chambers, which can impair systolic function and decrease the mechanic efficiency of contraction, which affects ventricular filling. Having mechanical dyssynchrony increases wall stress and worsens the presence of functional mitral regurgitation in heart failure patients. The most important association of extent of dyssynchrony is a widened QRS interval in the presence of a left bundle branch block pattern on ECG. So CRT requires placement of a pacing lead via the coronary sinus in the lateral wall of the ventricle. CRT synchronizes ventricular contraction by aligning the timing of activation of the opposing ventricular walls. CRT has shown to improve exercise capacity, reduce symptoms, and there's evidence of reverse remodeling in clinical trials, such as your CARE heart failure. There is uncertain benefit of CRT in acute decompensated heart failure with a right bundle branch block pattern, uncertain benefit of CRT in patients with atrial fibrillation, and those with evidence of scar in the lateral left ventricular wall where your CRT pacing lead is actually positioned. What about treatment of HFrEF patients who are at risk for sudden cardiac death? You may put in an implantable cardioverter defibrillator or your ICD. Sudden cardiac death due to ventricular arrhythmia is the mode of death in approximately half of patients with heart failure, and it is prevalent in HFrEF. When is an ICD indicated? You put in an ICD if 1. Patients have actually survived an episode of sudden cardiac death. 2. consider putting an ICD in patients with a New York Heart Association class 2 or 3 with a ejection fraction of less than 35%, irrespective of the etiology of the heart failure. And 3, you can put in an ICD in post-MI patients on optimal medical therapy with a residual ejection fraction of less than 30%, even if they are asymptomatic. Do we do any surgical procedures in heart failure patients? So, coronary artery bypass grafting or angioplasty is considered in patients with ischemic cardiomyopathy with multivessel coronary artery disease. We do the revascularization in those who present with angina and LV failure. What about surgical ventricular restoration? A technique in which there is an infarct exclusion to remodel the left ventricle by reshaping it surgically in patients with ischemic cardiomyopathy. SVR added to the bypass had no disease-modifying effect. Left ventricular aneurysm repair is advocated for refractory heart failure, patients with ventricular arrhythmias, or thromboembolism due to the presence of an akinetic aneurysmal segment of the left ventricle. More advanced therapies for HFrEF or for late-stage heart failure include your left ventricular assisted device, LVAD, and cardiac transplantation, which I will not discuss. We can also give supportive care for patients with HFrEF. Despite good outcomes with medical therapy, admission rates following heart failure hospitalization remains high, and half will be readmitted within 6 months of being discharged. The key to achieve enhanced outcomes must begin with attention to the transitional care at the onset of admission, with facilitated discharge through comprehensive discharge planning, patient and caregiver education, and a planned follow-up. Once heart failure becomes more advanced, a review should be done of the disease course, and the options with the patient and family regarding end-of-life preferences should be discussed. If the patient is at the end stage of their heart failure, such as your stage D, if they are not amenable to other therapies such as your CRT, heart transplant, LVAD, then you provide palliative care. So, this is the end of the topic on heart failure recognition and heart failure management. It is a long topic, but I hope I have presented what is heart failure, how to recognize heart failure, what to look for in the physical examination and the history of the patient, and what are the therapies given in heart failure as they target the mechanisms which cause the disease progression in heart failure. So thank you and have a good day.